the one thing you have to remember if you're going to be in public speaking, which I'm not, is when some people want to hear somebody talk, make sure that they're the ones that are talking and not you. So with that, I'm going to introduce two people that are the stars of the show, Jamie Mark and Jonathan Carlson. They do the DBS here in town, and work together with me and several others that we recognize. So with that, I'm going to hand the phone to Jamie, and they can just start educating us all about DBS.
Thank you. So we wanted to make today informative, but very open. You know, we do a lot of these talks where we kind of go over a lot of lists and inform people, but we want it to be something that patients can get something out of as well. So we're going to start, and I'm going to go over some of the aspects of DBS as far as who's a good candidate and the things that surgery can help, because that's a really common question that patients have. You know, I have this symptom or that, and is this going to help me? So I'm going to go over that, and then Dr. Carlson's going to go over some of the surgical aspects and show a nice video that was put together with a patient of ours. And then we have a couple of patients here today that are going to share their experiences, one of which is allowing us to turn his device off, and he gets symptomatic very quickly, so you can see what he looks like with the device off, and then we'll turn it back on and kind of show you the differences.
Okay, Jamie. So you're going to first talk about indications for surgery. Who's a good candidate, who's not? Look, can everybody see around the community here? Everybody in here, let's everybody raise your hand who's had a deep brain stimulator implant.
Raise your hand.
1, 2, 3, 4, 5, 6, 7, 8, 9. Well, if you take, so you double that because spouses are here. So at least half the group of people here have had DBS, so they can tell us what it's really like. Anybody around you who has had a deep brain stimulator implant, share with your friends and neighbors what it's like at the end of the session today. Okay, but what we're going to show you is, I think, some exciting, interesting information about it. This is a little more informal than last time because we basically put together a bunch of questions that we get asked all the time when patients come to see us and are trying to make a decision about surgery. So we're going to try and give you that information today. Okay, James, going to start.
And there are, what we're going over today, Dr. Carlson's office, Tina, in the back, was very nice to put together pamphlets of what we're going to go over. So don't feel like you have to write everything down. Jackie has the pamphlets, and some of you may have them around the room. And if you don't on your way out, feel free to grab one. An important aspect that we want to look at is who's a good candidate for surgery. Now, not everyone is the best candidate. Some people are probably better candidates in our eyes than others, and certainly that doesn't mean you can't have the surgery, but there are certain criteria or aspects that we definitely look for in patients to make sure we can benefit people and hopefully help them and not do any harm. One of the main things that we look at is that obviously people have what we call idiopathic Parkinson's disease. That means that you have a diagnosis of Parkinson's disease, and as part of that, you've had positive response to Parkinson's medication. Now, many people will come at the point of evaluation and say, well, the medicine doesn't help me much. And maybe at that point it's not helping, but early on, people should have gotten fairly good benefit to the medicine, so that's important. Making sure someone's memory and thinking is intact, that one isn't suffering from severe depression is important. Other things we look at is a patient's health outside of their Parkinson's disease. You know, sometimes patients will come in and they'll say, I'm 72 years old, would you still do surgery? And I'll say to them, if you're a healthy 72-year-old, that's more important to me than if you're 60 years old and you have uncontrolled diabetes and high blood pressure. So that's definitely something we're going to take into account as well. In looking at the different kind of patients that we see, you can kind of almost, in a way, and not that every Parkinson's patient falls into these categories, but you can kind of do some categorization of patients. First being the example of someone who's tremor dominant, but does not respond very well to levodopa. We've had about 4 to 5 patients now with a diagnosis of what we would call benign tremulous Parkinsonism, where people have a resting tremor that looks very much like Parkinson's. Otherwise, they really function pretty well, but they haven't had good response to levodopa or other Parkinson's medications. we have implanted them for the surgery with very good success in tremor control. So that may be someone that maybe a little bit more on the atypical side, but still could be a good candidate. We have people with young onset Parkinson's, and they have really extreme fluctuation between on and off. And some of you, even if you're not diagnosed at a young age, may be experiencing that before surgery, where you take enough medicine to get on and be able to move, but then it's enough medicine to make you dyskinetic. Unfortunately, if you don't take that much medication, you can't move and you're too off. So you're kind of between a rock and a hard place with the on-off fluctuation. And sometimes we get to a point where we've manipulated medicine as much as we possibly can, and then we have to move towards looking at surgery. Some people have what we would describe as unilateral Parkinson's disease, where their symptoms are primarily one-sided. In that individual, we may consider implanting just one side of the brain because of that. But what we've learned is over the years, generally at some point, the symptoms do present on the other side. So that's a consideration that we have to take into account. Are we going to implant just one side or both? I would say statistically, gosh, 90% or more of the surgeries we're doing, we're implanting both sides at the first surgery at the same time. And then you have patients who have kind of the moderate state of Parkinson's with tremor. They may have a little bit of dyskinesia. They may have some shuffling gait, slowness of movement, rigidity. But again, they're at a point where their medicines are no longer giving them enough benefit or causing too much side effect. Another kind of category that we've implanted a few patients with are patients that are fairly early into the disease, within the first, I would say, 3 to 5 years, and suffering from severe depression is important. Other things we look at is a patient's health outside of their Parkinson's disease. You know, sometimes patients will come in and they'll say, I'm 72 years old, would you still do surgery? And I'll say to them, if you're a healthy 72-year-old, that's more important to me than if you're 60 years old and you have uncontrolled diabetes and high blood pressure. So that's definitely something we're going to take into account as well. In looking at the different kind of patients that we see, to that screen. You can kind of almost, in a way, and not that every Parkinson's patient falls into these categories, but you can kind of do some categorization of patients. First being the example of someone who's tremor dominant, but does not respond very well to levodopa. We've had about 4 to 5 patients now with a diagnosis of what we would call benign tremulous Parkinsonism, where people have a resting tremor that looks very much like Parkinson's. Otherwise, they really function pretty well, but they haven't had good response to levodopa or other Parkinson's medications. We have implanted them for the surgery with very good success in tremor control. So that may be someone that may be a little bit more on the atypical side, but still could be a good candidate. We have people with young onset Parkinson's, and they have really extreme fluctuation between on and off. And some of you, even if you're not diagnosed at a young age, may be experiencing that before surgery, where you take enough medicine to get on and be able to move, but then it's enough medicine to make you dyskinetic. Unfortunately, if you don't take that, not looking at moderate memory difficulties or dementia is important. Reason being, if we implant someone and their memory is greatly affected prior to the surgery, we worry that we can make it worse with the surgery itself or the treatment after. Same is true for depression, making sure someone on much medication, you can't move and you're too off. So you're kind of between a rock and a hard place with the on-off fluctuation. And sometimes we get to a point where we've manipulated medicine as much as we possibly can, and then we have to move towards looking at surgery. Some people have what we would describe as unilateral Parkinson's disease, where their symptoms are primarily one-sided. In that individual, we may consider implanting just one side of the brain because of that. But what we've learned is over the years, generally at some point, the symptoms do present on the other side. So that's a consideration that we have to take into account. Are we going to implant just one side or both? I would say statistically, gosh, 90% or more of the surgeries we're doing, we're implanting both sides at the first surgery at the same time. And then you have patients who have kind of the moderate state of Parkinson's with tremor. They may have a little bit of dyskinesia. They may have some shuffling gait, slowness of movement, rigidity. But again, they're at a point where their medicines are no longer giving them enough benefit or causing too much side effect. Another kind of category that we've implanted a few patients with are patients that are fairly early into the disease, within the first, I would say, 3 to 5 years. Other things we look at is a patient's health outside of their Parkinson's disease. You know, sometimes patients will come in and they'll say, I'm 72 years old, would you still do surgery? And I'll say to them, if you're a healthy 72-year-old, that's more important to me than if you're 60 years old and you have uncontrolled diabetes and high blood pressure. So that's definitely something we're going to take into account as well. In looking at the different kind of patients that we see, and move down to that screen. You can kind of almost, in a way, and not that every Parkinson's patient falls into these categories, but you can kind of do some categorization of patients. First being the example of someone who's tremor dominant, but does not respond very well to levodopa. We've had about 4 to 5 patients now with a diagnosis of what we would call benign tremulous Parkinsonism, where people have a resting tremor that looks very much like Parkinson's. Otherwise, they really function pretty well, but they haven't had good response to levodopa or other Parkinson's medications. We have implanted them for the surgery with very good success in tremor control. So that may be someone that may be a little bit more on the atypical side, but still could be a good candidate. We have people with young onset Parkinson's, and they have really extreme fluctuation between on and off. And some of you, even if you're not diagnosed at a young age, may be experiencing that before surgery, where you take enough medicine to get on and be able to move, but then it's enough medicine to make you dyskinetic. Unfortunately, if you don't take that much medication, you can't move and you're too off. So you're kind of between a rock and a hard place with the on-off fluctuation. And sometimes we get to a point where we've manipulated medicine as much as we possibly can, and then we have to move towards looking at surgery. Some people have what we would describe as unilateral Parkinson's disease, where their symptoms are primarily one-sided. In that individual, we may consider implanting just one side of the brain because of that. But what we learned is over the years, generally at some point, the symptoms do present on the other side. So that's a consideration that we have to take into account. Are we going to implant just one side or both? I would say statistically, gosh, 90% or more of the surgeries we're doing, we're implanting both sides at the first surgery at the same time. And then you have patients who have kind of the moderate state of Parkinson's with tremor. They may have a little bit of dyskinesia. They may have some shuffling gait, slowness of movement, rigidity. But again, they're at a point where their medicines are no longer giving them enough benefit or causing too much side effect. Another kind of category that we've implanted a few patients with are patients that are fairly early into the disease, within the first, I would say, 3 to 5 years. And they've definitely gotten response to the medication, but they can't tolerate it. So they can't ever take enough medicine to feel good enough and get good enough symptom control. So we have also implanted a few individuals very early into the disease that would like to take more medicine, but they can't. And we've had some good response with surgical outcomes and limiting the amount of medicine that they take. So those are just some general categories for you of patients presenting to us and who we would look to implant. Certainly there's people on ends of the spectrum that we take at an individual basis and look at people and really evaluate them. But again, when you come in, it's important to go over your goals with surgery, what expectations you would have with surgery, and for us to kind of talk to you about the things that we think we can help and the things that we would not expect to be better. And then we have Dr. Carlson talk about the surgery a little bit.
This one?
We know, I know most people in this audience, and I'm sure Jamie probably knows everybody in this audience just about, but I think we should do some introductions for people around the state. So Jamie Mark is a nurse practitioner who manages over 300 Parkinson's patients with deep brain stimulator implants. So she has a vast experience over a decade of managing patients like all of you, which can be quite complex and difficult. So she's extremely skilled and experienced. She works with Dr. David Greeley, who is our local neurologist, movement disorder neurologist here in town. And I'm Jonathan Carlson. I'm a neurosurgeon in town. I work at Inland Neurosurgery and Spine. There are 2 of us in that office who do deep brain stimulating implants, and we have a really active program in DBS. And Jamie and Dr. Greeley and Dr. Hirschauer is my other partner, and I are the core group of people who do this surgery. So DBS surgery is my favorite thing in the world of neurosurgery, because there isn't much that a neurosurgeon can do to make people's neurological deficits better. You know, somebody has a brain tumor, you can kind of take it out, but they're still not going to be normal. In Parkinson's disease, and particularly tremor, I can really make people better, which is very exciting. So I'm going to show you some movies of that, and those movies I'm going to narrate, but they're going to answer a lot of questions I think people have about the surgery itself. Okay. Before we jump into the movies, do we have any questions? Okay, let me summarize one thing for Jamie. Jamie went through a long list of things that we can do to treat people. Let me tell you the symptoms of Parkinson's that we can help and the symptoms we cannot help very well. Tremor, we can almost completely stop. Rigidity, we can help quite a bit. Slowness, we help somewhat. Some patients still remain somewhat slow, but they get better. Walking gets better in most patients, but not everybody. Gait freezing does not often get better. Sometimes it gets a little worse. Speaking sometimes gets a little bit worse. Having problems with slurring the words. And those are the cardinal symptoms. Any questions? Uh-oh. Back there.
Can you say what percentage of Parkinson's folks are eligible for this type of surgery?
Yeah, that's a very important question. What percentage of patients with Parkinson's disease are eligible for deep brain stimulation surgery? The answer to that is that the vast majority of patients are eligible when they reach a certain state of the disease. We don't do DBS surgery for patients who just got diagnosed and whose medicines are working very well, because there's risks associated with the surgery. So we wait until the medicines are not working as well as they normally do before we do the surgery. Pretty much any patient who has regular Parkinson's disease will advance through stages. They start out with medicines working perfectly, they maintain their regular life, they continue working, but eventually those medicines start to lose their efficacy. The doses go up, and they start getting wearing off. So most of you here know what that is. That's when you take your pill, and after a couple hours it stops working. And then, as you take your Parkinson's medicine, you get dyskinesia, which is a very bad and difficult complication and side effect of the medicine. So when patients reach the state of motor fluctuations with dyskinesia, that's when they become eligible for surgery in my book. Before that point, it's pretty unusual. Patients who have reached a stage where they're almost unable to walk, so they have to use a wheelchair to get around outside the house, you know, I can make them a little bit better, but I can't make them dramatically better with surgery. So there is a point late in the disease when surgery is probably not the right decision. There's kind of a little window within the disease that you're a good candidate. Does that answer your question? Joyce?
Having had the surgery, I would say you get better strength and you're less fatigued.
Okay, that's very good insight from patient Joyce Rudine, who is one of my patients we operate on. She says that she got a lot of extra strength and energy after the surgery. Okay. All right, I got two movies to show you. One is of a patient with just tremor, and she's one of those Parkinson's patients that maybe it's essential tremor, maybe it's Parkinson's disease tremor, it's kind of in between. And then I have a patient who's relatively young, who has typical one-sided Parkinson's disease that we treat. Let's see if I can get this to work. Now you get to see all my movies. Okay, I'm going to narrate this. This is a homemade movie, you'll have to forgive me. I'm not much of a movie maker. Okay, so this is our patient, she's a nice young lady, very young in the world of Parkinson's disease. So when you come to surgery, this is the day of the main surgery when we implant the electrode. You check into the operating room, they take you downstairs, they put an IV in you, they put a surgical gown on you, and we make sure we're doing the right surgery. Basic stuff when you check into any kind of surgery. You're going to see a bunch of technology that we use in these cases.
The frame's nice and light, isn't it?
To begin with, we put a frame on your head. That's a picture of the frame. And it's very important to have a precise reference frame because we're very accurate in what we do in the brain. Our accuracy is less than a millimeter. This is the worst part of the day. It looks like a torture machine, right? How many people have had the torture? It's not that bad. We numb your skin up like the dentist, and then we screw these things into the surface of the skull. This may look kind of traumatic, but there you go. I didn't care to say that. Okay, so here's your symptoms. You're going to see them go away at the end of the day. It's a little bit of tremor. There's a lot of stiffness and rigidity and slowness of bradykinesia in her right side. So we're going to put a wire in her left brain for her right side. Very slow hands. She's been off all of her medicines overnight, so she's really off. Normally she's a little more functional this when she takes her medicines.
This is the fiducial system that we use to calculate the coordinates for the target.
Okay, so we get the frame on, and then we go to the CAT scanner. We get a real quick picture. It only takes a few seconds to get the scan, so we don't put you in an MRI scan. We've already done the MRI. If anyone has any questions, stop. We'll answer them in the middle. Okay? So we get a quick CAT scan, and then we go to the operating room. So here we go. So we get you comfortable on the table. This frame that's attached to your head actually becomes your pillow. We have an X-ray machine that surrounds your head. There's enough space in there.
Yeah.
She's saying no problem at all. But you can see how nervous she is. Okay, everyone asks me, how much hair are you going to shave? Well, it depends on the surgeon. I try to shave enough hair that I don't get any hair in the wounds, but I leave most of the hair. Okay? So we shave a little window, and I sterilize the hair. It's very important to be sterile. Despite everything we do, we still get infections in the surgery. Okay, we use a lot of technology in the surgery. One thing is we use an MRI scan, and then we use a specialized computer to pick the spot in the brain that we're going to go to. And that's what you see here is a simulation of where the wire is going to go inside this patient's brain. So then we cover you with a bunch of plastic so that where I am is sterile to operate inside. And on the other side, you're able to be awake and look around and talk and communicate. So here you go. There's Jamie on the other side. Okay, here's some of the technologies. This is a simulator where we can attach the frame. This is the frame itself that attaches to the patient. This is the target where we want the wire to go inside the brain. It's a simulation. And this equipment lets us go to that spot from anywhere on the surface of the brain. It's really neat equipment. It's old. This stuff's been around for about 40 years. Long time. Basic technology. So that attaches to the frame that's on the head. And then we go about, we give you some anesthesia so you don't remember anything. And we give you a little bit of happiness, and I'll skip that part. Here's the hole. Okay. Didn't want to gross anybody out. It's just that we want to show. So we make a hole about the size of my finger. And through this frame, we attach this device that lets me move things in 1 micrometer increments, which is 1,000th of a millimeter. So it's extremely precise. Here's, you can't see that picture of the microelectrode. This is a little microphone we use to listen to the cells in your brain. Hear that popcorn? That's an individual neuron depolarizing. And sometimes we find cells that are synchronous with tremor. So this was a nice case of synchronous tremor. Okay, once we are happy with where we have picked in the brain, we confirmed it with a microelectrode recording, then we actually stick the DBS wire. And then we do some testing with that, and we see what it is. Okay, sometimes just sticking the wire in there will make things a little better. So let's jump to the end, because we got a lot to talk about. Okay, so she's a little bit slow. See how she doesn't really use her pinky and she turns into a tremor. So then we turn the stimulator on in the operating room there. And now the whole hand is working. Thumbs up. There's Jamie. So there you've seen the basic elements of what happens in surgery. Does anybody have any questions? Yes?
That's a good example for somebody that has tremor, but if you don't have tremor during the surgery, how do you know it's working?
There's other things besides tremor that we test for. One is bradykinesia, which is the slowness of the hand. Usually the hand speed will increase as we stimulate. The other thing that we test a lot for is rigidity. A lot of patients have pretty significant rigidity, and as we turn the stimulator on, the rigidity will almost just go away and their hand will become floppy. Those are both really good signs in addition to the tremor suppression. In fact, they're better than tremor suppression in the operating room. We're always able to get a little bit better tremor control in the clinic when we adjust the stimulator after several months. So there's other things we test, yeah.
What are complications of surgery and how common are they?
Okay, very good question. What are the complications of surgery and how common are they? This is brain surgery, and it does not come without risk. In other words, it has risk associated with it. As far as brain surgery goes, it's pretty low risk. The worst, I should say, the most common complication we have is an infection. And the infection rate runs around 1 in 20 patients, or 5%. When you get an infection, it's usually not a big problem. We have to take the wires out, take the generator out, and we put you on antibiotics for a few months, actually for 6 weeks usually, and then after a few months we can put the generator and the wires back in. So it's a reversible complication. There are irreversible complications from the surgery. One of them is a brain hemorrhage. Anytime you stick wires in the brain, you can cause hemorrhage. Most hemorrhages are pretty small and patients will have some temporary weakness. There's the rare patient that will have a really large hemorrhage and will end up paralyzed or even die because of that down the road a few months. So there are some life-threatening risks. The risk of the life-threatening hemorrhage is about 3 patients out of 1,000. So 0.3% is pretty small, but it's not inconsequential. And that's why we kind of wait till patients have reached a state of their disease when they're partially disabled from it, so that the risk-benefit trade-off is close to equivalent. Yes?
I understand that the surgery will help the patient for a period of time, but the disease continues to progress. Is that true?
Yes, that's correct. The question was, let me rephrase your question. How long does the effect of the surgery last? The answer is, it depends on which symptoms you're looking at. I usually tell my patients that the things that we're really good at treating will stay away forever, like tremor and some rigidity. The things that the surgery doesn't help very much will continue to get worse. Usually at a little bit slower pace, but they'll continue to get worse. If you think of Parkinson's patients doing really well for several years, and then in the overall wellness scheme, they start to go down this steep curve. They start getting worse rapidly over 6 months to a year. But we try and get the patients just as they start going down that edge, and we push them back up that curve 3 or 4 years. But they're still going to end up going back down at some point. They get problems with walking and posture. The surgery helps a little bit, but those symptoms keep coming back. The surgery itself is like medicine. It treats the symptoms of Parkinson's disease. It does not treat the loss of dopamine cells in the brain. It's a different mechanism. So it lasts for a long time, but other parts of your Parkinson's disease sometimes catch up with you. Yes?
How do you program the generator, and how often do you typically make adjustments to that?
Jamie, you want to answer that? That's Jamie's job. All I have to do is put him in. She has the hard job. Because it's very difficult and complicated.
So the good news is, once you've had the surgery done, the rest of it's non-invasive. So I use a programmer, and it has a little wand that comes out of it, and you just set it right on the patient's battery, and then I can make changes with the programmer itself. So that's nice because, again, after the first two surgeries that we do, it's non-invasive, but it can take a long time to get things where we need to be. I usually, depending on how often patients can come in, want to see patients every 2 to 4 weeks for the first few months, and then we'll spread it out based on how people are doing. Sometimes by a year out, people are pretty stable, and I may see them once every 6 months. People who are continuing to have difficulty, and oftentimes it's not just an issue of programming, but maybe medicine adjustment, or they need physical therapy, or they're having sleep issues, or having depression, memory issues. I might see them as frequently as every 6 to 8 weeks, depending on how they're doing. So it's pretty intense after the surgery for the first 6 months to a year.
It's a good way to make your doctor take care of you, because you do come in a lot. And this lets me get to another point, in that this is not a solo job. This is a team effort. It really takes a team of doctors and specialists to take care of you. And that's one thing I think we have very unique here in Spokane is a very skilled and experienced team of doctors and clinicians to help take care of you. So I think we've got a good program here. Other questions?
Oh.
If you have the surgery and somewhere 5 years from now or whatever, they discover something that actually treats the disease rather than just the symptoms, does the fact of having had the surgery have an impact on your ability to be treated for the, or do we not know at this point?
Good question. Let me say it for everybody. Your question is, if you get deep brain stimulation surgery, does that mean you can't get other treatments that might develop in the future that could treat the underlying disease? The answer to that is yes and no, like most things in life. Most of those things are experimental, and it takes decades or 5 to 10 years for those experimental treatments to reach FDA approval that we can use in the general public. At the time that you would become enrolled as an experimental subject, almost all studies would exclude you if you had prior brain surgery. But I'm pretty up to date on most things with Parkinson's. As far as I know, in the next 5 to 10 years, there's nothing really probably that's going to really change the treatment of Parkinson's disease, at least for the next 5 or 10 years, that's going to be FDA approved to the general public. We've tried a lot of things: fetal graft, adrenal graft, replacing dopamine, GDNF, tube implants for growth factors. All of these show some kind of scientific benefit, but they don't have a lot of clinical impact on patients. They work really well in rats. I know a lot about rats too, by the way. But when it comes to actually fixing people, none of them have been a giant success, nothing on the order of deep brain stimulation and the like. So if you're worried about that, that's reasonable worry, but my personal opinion is that that's not a reason not to treat you as you are at this point. Okay, next question.
How long does a battery pack usually last before it has to be replaced?
Well, it's like any battery. It depends on how much electricity used. And sometimes, I'll tell you that the simple answer is anywhere from a year to 3 or 4 years. It depends on how much electricity we use. You agree, Jamie?
With the new batteries, we have some brand new batteries out that one patient actually here today is going to come up and talk about his experience, and he has the new battery. The longevity of it might not be as long. We haven't gotten a good indication because we just started implanting these in November, the newest battery. But in general, for a Parkinson's patient, 3 to 5 years is a good estimate. I have patients that definitely we have to program at higher settings, and they run through their batteries a little more quickly. But I always tell patients, at the end of the day, I want you doing well, and if that means you require a little higher setting, I'd rather have you get quality out of this device and get the battery replaced sooner than not get benefit from it. And luckily, the surgery for replacement is much easier than the initial surgery.
Okay, I got one other movie to show you. This is a lady primarily with tremor. This is a short movie, and it's much more of a home movie than the other one. And it's shot on my iPhone. Anybody have an iPhone? 1, 2, there's only 3 of you. You gotta get an iPhone. It's really amazing. So this was shot on my iPhone. And she did not have a deep brain stimulator implant because of many different factors we could go into maybe afterwards. She had a thalamotomy, which is essentially the same thing, except it's a permanent lesion rather than electrical stimulation. But the clinical effect is identical.
She's got Parkinson's.
Her tremor is so severe that she can't feed herself. She's unable to, and she doesn't want to go out to eat because it's embarrassing. She can't write a check. Those are the kind of thresholds that we use for this kind of treatment. Here she's trying to draw a spiral, and then she's going to sign her name for us. This is in the pre-op area before surgery, so she's a little anxious. You see, she's trying to stabilize her hands so that it'll look good. Her tremor is pretty bad. Takes her a while to write her name there. Okay, illegible. I mean, you can sort of make it out there. So here she is trying to take a drink out of her cup. You can see how she would have a problem drinking. So we're in the operating room. This is kind of an abbreviated section of video here that just kind of shows you the effect. This is before we've done anything. Okay, why don't you take a drink there, Evelyn? Sometimes just sticking the probe in there will help her tremor a little bit. That's what you see here. And here comes the juice. Here, I'm heating it up. There, the tremor's coming. Yeah, we only treated the left hand in her case. As you can see, we only treated this hand. This was the bad one. And this is the one that's untreated. This is so we're getting an effect there. So here we are after surgery. Touch your nose with this finger. No tremor. Touch my finger. Touch your nose. Pretty amazing. How's it feel? Okay, here she is 3 months out. Right out Miami with Evelyn Hetherington. She's still having good tremor control. Go ahead. She's drawing a straight line. Great. Just sign your name. Much easier to read. Still a little bit slow here. She has just a little bit of tremor, but compared to beforehand, it's functional. She can use her hand to do things and take care of herself. And there you can see the tremor on the other side. And there's a little bit of tremor there. It's a little bit of shakiness, but it's pretty good. Still working. Okay, here's a picture. That's what she looks like after surgery. So it's pretty effective for tremor. Those of you that have bad disabling tremor, it can really make you better. Handwriting. Parkinson's handwriting that's non-tremorless gets a little bit better. It doesn't always get dramatically better. Sometimes it gets a little bit worse for a while. Okay. Anybody have questions about this?
I have a quick question.
Yes.
After surgery, I've heard that some patients can take less medication. Can you speak to that?
Very good question. After surgery, I hear that patients take less medicine. That's precisely correct. On average, it's about 2/3 the dose it was before surgery. And that's despite doing better. Patients who get really bad dyskinesia benefit a lot from the surgery by reducing their medicines so they don't get the dyskinesia. The surgery actually works as if it's like taking medicine. The clinical effect is like taking a Cinemed or a Parkinson's pill. We don't exactly understand how that works, but the clinical, on the surface, the clinical effect is pretty similar to that. Some patients will take dramatically less, and we have a handful of patients out of hundreds who will stop all of their Parkinson's meds. That's pretty unusual. And that's not really the goal, in my opinion, either. But some people do so well, they don't need to take any. Yes?
My question is there any decrease because of the damaging of those cells? Is there any decrease in the ability of the person to making a quick decision, like in saving their lives? Is there sort of is there a lack of making a decision? Let me ask. That's the question.
Good question. Is there, after surgery, is there a problem making decisions? Let me rephrase your question. What does DBS stimulation do for the cognitive, your ability to think and remember and to use your mind and to reason? There's a lot of neurocognitive scientists or psychologists who have studied this. So they do a 3 or 4 hours of all these cognitive testing, your language and your verbal memory and your nonverbal memory and your visual spatial orientation and your frontal lobe. There's a bunch of tests. People spend their whole life doing it. So they give these tests to patients with Parkinson's disease and then they test them afterwards. And in the vast majority of those tests, patients do the same. In a few areas, they do a little bit worse. We don't understand why, but it's just a little bit worse. There's some patients that get quite a bit worse, but most patients actually stay the same or say they feel better in their mind. The area that gets a little bit worse has to do with verbal language processing. They're a little bit slower in using words. Most patients who are young, who don't have dementia or any kind of memory problems, don't have any obvious impact on their ability to think.
How about motor skills, like the skill to drive and react to situations that way?
Driving. Jamie, why don't you talk about that one? Driving is, it's always hard to take away a driver's license. I'll let Jamie answer that one. I usually say go see your neurologist.
Driving is a difficult issue. You know, for most patients, if they were not driving before surgery, it depends on why they weren't driving. Is it because of physical issues, memory issues? So it really depends on that. I have had a few patients that prior to surgery were not driving because of tremor or dyskinesia. After surgery, they're actually a better driver because those things have been improved. So across the board, we have to take it case by case. I've had some people, again, that weren't driving and then were able to, and vice versa, just depending on the situation. So it kind of depends on why they weren't in the first place. Yeah.
I was curious, the infection rate seems a little high. 5%. You might take prophylactic antibiotics, and if you use this due to the fact you have two different sites when you're operating, then the topical and the other, or these wires not buried, or?
The question is, the infection rate seems kind of high. Why?
I was working surgery, so I was around 1 to 2%. So I was
Yes.
high.
It's a very good question. And to be very honest, my infection rate is around 5%. If you look at large published series, the infection rates range between about 3 to 5%, all the way up to 20%. And infection is the enemy of this surgery. And we do use prophylactic antibiotics before and after surgery in the typical way. Like any implant that we put in the body, it's prone to get infected more than just surgery without an implant. And this is a difficult spot, particularly the subclavicular pocket and the spot behind the ear. It's kind of sensitive, soft skin. Sometimes patients pick it, and I think that can sometimes cause an infection. Sometimes it's just surgical contamination. There's no perfect way to beat an infection. Unfortunately, that's the real number, and that's what we tell patients. So.
I think Dr. Carlson talking about how it's been, you have to have in the brain, it's been the pocket.
Yeah, it's very unusual to get one in the brain. It's usually in the pocket or the area behind the ear. So it doesn't usually affect the brain.
I think that in your seminar, you should tell them about to bring an ice bag to put on their head the next morning, or that night of the first operation.
Did you get a black eye?
No, it was swelling and a lot of pressure in that TIG turbine, and that ice bag just immediately, very little ice, some water, so it's not too heavy. It just made it terrific. And Bill Bell out of Seattle emailed us and told us to do that. And I think that's really a lifesaver.
That's good.
It really helped.
The comment is, for those of you who are soon to go surgery, use some ice after surgery. That'll reduce the swelling.
Get the large one.
Big ice bag. You don't want to freeze your head. Okay, let's show a patient. Gary, come on up.
this is Gary Owens, and Gary, when did you have your surgery? How long ago has it been?
My secretary.
It's a good thing his wife comes to the building. November of '08, so we're a year and a half out, and prior to surgery, you had what symptoms?
Walking, talking, slurring, drooling, shaking, miserable.
Gary, I remember when he came in, had a lot of tremor. That was obviously something that we saw, but a lot of difficulty with walking, difficulty with speech, drooling, a lot of other things. And again, this is, you know, there are examples across the board in improvement. Part of the reason I wanted Gary to come today and turn his device on and off is because you can see the difference in him immediately, both when we turn it off getting worse and when we turn it on getting better. So not every patient responds this quickly, better or worse, but it makes it, sure, we'll move over here. But this is just a good example and representation beyond just tremor of what you'll see. So I'm going to turn this device off and just leave it off for a minute or so, and then we'll turn it back on.
Does he have bilateral or just?
He does. But interestingly, if we just have to really only turn one side off to see the difference.
And it's hard to talk.
So does the stim inhibit the tremor?
Hang on just a second. Can you walk? Can you even attempt to? Okay, hold up. Okay, so I'm gonna turn it back on.
He thinks he's 20.
That's no problem, right?
We've always had 200 employees in the construction business and restaurants and farms and apartment houses. And it was all, you know, we used to being busy, so we retired. And life was just worthless. When I got the Parkinsons, you know, after doing all the business. So now I went back into business. And we have a 200-acre farm. And we're farming our 200 acres and raising hay, and life is great. I just built a 10,000 square foot building, barn, shop, bought 3 tractors, 3 swathers, and we're back in business. Because sitting around like that really makes you mindful of how precious life is and how you want to stay busy. And by staying busy, I feel better. And it's a wonderful operation. I recommend it. We even see. It's a lifesaver.
When you go to sleep, does it diminish his trend 24 hours a day?
Yeah, so he keeps his device on, which most people with Parkinson's would keep their device on 24 hours a day. And part of that is because with Parkinson's, not only do you have trouble in the day, but you have trouble at night. You know, you might tremor when you wake up, you might be really rigid and uncomfortable in bed, you might have trouble getting up to the bathroom, and so we keep it on. The other thought is that with the stimulation, you know, again with Gary, you can see that immediate on-off, but for most people, we think it has to stay on for some amount of time to see the benefit from it. So if people turned it off and turned it on intermittently, they just might not see the full benefit from it.
One other point.
Yeah.
Before the operation, I'd kind of roll over in bed and get just enough of weight, because when you're asleep, it didn't do it. But you wake up enough just rolling over that all of a sudden you're shaking again, and then you can't get back to sleep. So your rest, you don't get good rest. After the operation, you sleep like a dog.
We didn't talk about this works for so long, and this works for so long, and we have to change it back after that. Is there some kind of lifetime limit to this
The device?
Yeah.
That's a good question. Ed asked, is there a lifetime limit with the device? And no, our experience is implanting people for Parkinson's specifically, we started back in 2000, not just for tremor, but for the disease more entirely. And we have people that are 10 years out that still have benefit, that still keep their device on. There are studies in other parts of the nation and in Europe that go out 15 years where people are still getting benefit. Now granted, they're not going to get as much benefit 15 years out that they did the first year, but as Dr. Carlson described before, hopefully things are more stable over time than they would have been otherwise.
I want to say something too.
Yeah.
You have a dramatically good effect. Not everybody has as good benefit from the surgery, which is one of the really puzzling things about DBS. Patients can look the same on the surface, and some people have a very dramatic effect. And some people it helps a little bit, but not as much as we expected. We have yet to figure out why that's the case. I don't think it's from where we put the wires. It just has to do with the nature of your disease. So people should realize that not everybody does as well as you,
One other
but
thing.
some do.
The first night, they kept me overnight the day of the operation so that I could see if I bled or not. The second operation, a week later, where they hooked the batteries up, they hooked them up and I left. Dr. Hirshheimer let me go home, and I think, at the hospital, they wake you up to give you a sleeping pill. So, the sooner you get out of the hospital, the better off you are. That's why it gets so good. Anyway.
I have a real quick question. With the deep brain stimulation, with the amount of electrical impulse going into the brain, does it cause any kind of possible atrophy to where it would keep the individual from actually progressing?
Yeah, there's 2 parts to your question. Your question was basically, does the stimulator do any damage to the brain tissue in the long term that's being stimulated? The answer to that is collected from patients who have died, who donate their brain to science, and then we look at that tissue under the microscope. And there's a very small, about a 1/4 millimeter area of injury around the margin where the wire is. But that's about all the injury that we see, quite surprising. You would think that long-term electrical stimulation of the brain would cause some permanent scarring or something of that nature, but we really don't see that. The amount of electricity that we use is not damaging the brain tissue. It's not like a welding machine or anything like that's going to burn the tissue. It simply stimulates the brain tissue like a regular neuron would be stimulated by another neuron.
Thank you.
Joyce?
Does having Parkinson's lower your life expectancy?
So the question was, does having Parkinson's lower your life expectancy? Probably would depend really on the age of diagnosis. Parkinson's disease itself isn't a fatal disease, but it is one that can cause complications, especially as people have had it through the years. I've managed patients who were diagnosed at 50 and they live till 80 and they have a heart attack, and that's why they ultimately pass away. So, yeah.
I'm sure there's some epidemiology data out there. I don't know the answer to that. Yes?
You mentioned that it's common to decrease the amount of medication that the patients take after surgery. Do they usually stay on the same drugs that they were taking before?
Yeah, typically it's the same medicine but less of them. And sometimes we can even, most of the time, by the time people are at the point of surgery, they're probably on 3 or 4 medicines, some people may be. And so it may be that we can get rid of some medicines entirely, but in general, they're going to be on the same medicine but less. Most people end up on some amount of levodopa still, depending on how they tolerate it, because that medicine is good for physical aspects of the disease, but also some emotional aspects, and that's why we really don't try and encourage patients to totally get off the medication, because sometimes physically they're doing fine, but emotionally they might feel a little unmotivated or depressed. So sometimes we keep people on a little bit of medicine for that aspect of the disease more than anything.
Okay, I just got a couple more things to say. We have more people in the audience. We have more of our team in the audience here. Why don't you go ahead and stand up. We have our research team here that's getting started. Yeah, that's you. Josh DeMeyer. We've got several people back here who are part of our research team. So we're embarking on a new phase of our program, and that's to do a little bit of science on our patients. So we hope you'll be interested and contribute to that when we get to that stage. Okay.
And just one quick thing, I represent the 14 other stations that are out there in the airway wanting to get questions in. So we're going to go out to the airways right now and ask questions and just see what the people want to know out there in television land. First call is going out to Deaconess Billings Clinic.
Deaconess Billings Clinic, any questions? Anybody?
How much interference is there with things like microwaves and so forth?
How much interference is there from microwaves? Well, I wouldn't stick your head inside the microwave. There are some precautions for when you have surgery in the future. They should be very careful using what's called electrocautery. But for the most part, these things do not seem to be much of an antenna. They don't seem to pick up regular electromagnetic radiation that you have in a typical room. You have to be very careful with MRI scans. You can get an MRI, but it has to be a very special MRI scan done by somebody who's a specialist with DBS. Okay.
And just of the brain.
Just of the brain, not of the spine. Well, the airports, who knows what they're doing to you at the airports? You might want to, like the guy say, I have some brain implants. Another question.
Okay, another one is from Coeur d'Alene, Idaho.
Coeur d'Alene.
Coeur d'Alene Kootenai Medical Center.
Coeur d'Alene Kootenai Medical Center.
We have two questions.
Two questions.
First question.
Do they implant if one side is affected, just put one implant on the side of the brain, or do they do if you're both sides, if you have both sides affected, brain in the area of the brain?
Okay, I got your question. Do they do just one side of the brain when you have symptoms just on one side of the body? The answer to that is yes. Early in Parkinson's disease, it's usually just on one side. And we can put a stimulator in to treat just one side. Second question.
Second question. Yes, another question. I can't think of the name of the procedure where you go in and you destroy actually part of the brain. It starts with a P and ends with
Pallidotomy
or something.
Yeah.
Will you speak to that, please?
Yes. A little history. The procedure you're thinking of is called a pallidotomy. Before the deep brain stimulation equipment and the technology was developed, we would treat Parkinson's disease with lesions. And the two names for that was pallidotomy and thalamotomy. Those are two different spots in the brain. It's the same place that we now put stimulators. So it's an uncommon surgery nowadays. I've done a few of them recently, but for the most part it's uncommon. Most of the time we put in a stimulator. But the clinical effect is pretty similar. There's a lot of literature and old stuff on the internet about pallidotomy, if you dig really deep. Okay.
Next question is
You take a question from Walla Walla.
Okay, Walla Walla. Walla Walla, do you hear us?
Providence, St. Mary.
Had Parkinson's for about 10 years, and then I've had it now for about 10. When she had a surgery, she went for gallbladder surgery, and she never came out of it. Her mind never, I wondered if it was from the Parkinson's. She did not have the deep brain stimulation, but I'm always worried about having to have a surgery with Parkinson's.
Yeah, I think you touched on an important point, and that is that the brain of somebody with Parkinson's disease is a little fragile. And anytime you undergo anesthesia, sometimes it doesn't quite wake up as good as it was before. And some patients with Parkinson's disease stay in the hospital longer and normal. That's just something everybody should be aware of.
Okay, Sandpoint, Idaho.
Sandpoint.
So when he calls us, I'll unmute it. Ask your question.
Is anybody in Sandpoint? Okay, next one. We're missing that one.
Okay, this one is from Seattle, Virginia Mason.
Virginia Mason. Britsville.
I don't know if they have us on though, because we didn't come on till late.
Well, you're on here.
Any questions in Ritzville, Vicki?
Just a minute, yeah, maybe, you have a
Yes.
question? Okay, go ahead.
I've had to go to an eye doctor, and I've had some eye problems, and I don't know whether it's connected to this or not, but I have to go back, and now I was in just 2 or 3 days now, and check and see if the problem is better. He gave me a 2-week supply of drops. He used it in one eye and told me to come back in 2 weeks without using it. I'm getting close to going back now, but I think it has helped. I'm worried about my eye. Is this thing causing any of the damage?
Do you have a deep brain stimulator?
No, he doesn't,
Okay.
no.
Do you have glaucoma? Is that what your eye drops are for?
The first ones were that they gave me, but not now.
Well, I'm not sure what that's about.
He gave me, but not glaucoma.
He,
There's a fatty kind of fatty issue in there.
Well, that's not necessarily related to Parkinson's disease, so I don't know if I can help you with that question.
Well, I'll wait till I get over this next 2 weeks, I guess. A lot of this has,
I hope you get better.
Let's ask it.
yeah, I've been
Tenasket, North Valley. Tenasket.
Okay, let's take a question from Tenasket, North Valley.
Yeah, it's Tenasket here. Just wondering, in the patients that you do the surgery with, what is the percentage of patients over the age of 70?
Well, as Jamie had noted before, the age is not so important as the patient's overall bodily health. I think a lot of our patients are over 70. Over 70 is not a problem. I would say that the highest threshold I've done is 85. That's pretty old. But there's some people who are 85 that look 60, like most of you. Oh, do we have Alaska all the way up there? I hope it's warm. Anyone in Alaska?
Well, we have sun. We have
Sun.
But we have a question.
Okay,
We
go
have a
ahead.
question in regard, is DBS, if your stroke-induced Parkinson's, is DBS a possibility?
Probably not. The answer to that is complex, and it depends on your specific situation. The contraindications, so the diseases that look like Parkinson's disease but that we don't treat with DBS are the following. Parkinson's plus syndrome, like Shy-Drager, progressive supranuclear palsy, cortical striatal microdegeneration, and post-stroke Parkinson's and post-encephalopathic Parkinson's disease, which is basically a disease that doesn't exist anymore. That's what was on that show, the TV Awakening, the movie Awakens. So post-stroke is usually associated with other neurologic deficits as well. And in general, patients who have had large strokes, we usually don't treat with DBS, even if they have regular Parkinson's. Sometimes we do. Okay, is that everybody around
Thank you very much.
Northwest?
No,
Good.
And now ask for.
You didn't call for Clarkston.
Okay, Clarkston, we missed you. Go ahead.
Yes, we have 3 questions. How is our knee and hip surgery replacement affected by DBS? And after this, I have 2 more questions.
Well, if your brain is not working and your knees and and hips aren't working, we can fix them all. We usually, well, I can't do that. I can fix your brain. But we have patients who've had hip replacements who then go on to have DBS. That's not a problem. We have the other way also, patients who have DBS and then later on they go on to have hip and knee replacements.
Thank you. Okay, can a person on heart medication have a DBS implant?
Yes, we treat all patients with heart conditions. Sometimes we get scared off. We don't want to have a heart attack. But our anesthesiologists are very good, and we're experienced at taking care of heart disease in the hospital. And that's not a reason not to have the surgery. Even if you're on Coumadin, we might do it.
Got it on brain, I don't know.
Okay, now the third one is, if the patient has balance and or fatigue problems before, does DBS help it?
The answer to that is that sometimes it helps quite a bit. Most of the time it helps a little bit. It's rare that surgery makes it worse. The part that it helps the most is when somebody has really bad fluctuations. So if when they're off, they can't move, but when their pills work, they're able to walk, we can usually help their walking balance quite a bit because they don't get stuck in that off state. And you saw a good example of that here today. Okay. Lots of questions.